Dr. Professor Mondip Kaur is about to speak on.
Thank you, Dr. Nagpal. Thank you so much.
My topic is IV fluids and parenteral nutrients. So before I go to the topic, let's talk of a few terms and few things which are pertinent to the talk. Fluid compartments. As per the body water, it is distributed between two major fluid compartments separated by cell membranes. That is intracellular fluid and extracellular fluid. Extracellular fluid is further divided into interstitial and intravascular fluids. Then there are osmotic forces created by the trapped solutes which govern the distribution of water between the compartments and ultimately each compartment's volume. Now, for these osmotic forces that I've talked, two terms are very pertinent, osmolality and osmolarity. These always confuse the PG students. Let's make it clear. Osmolality is the number of solute particles in 1 kg of solvent. And changing osmolality of one compartment affects osmolality of the other compartment. Osmolarity refers to the number of solute particles per 1 liter of solution. And then solutions could be isoosmolar, hypoosmolar, or hyperosmolar, depending upon if the solution has same amount of particles and water, it's isoosmolar. Solution with fewer particles than water is hypoosmolar, and hyperosmolar has got more particles than water. Now, again, this is the composition of intra and extracellular fluid compartments in milliosmoles per liter. Here, this chart is given in every book, but I wish to focus your attention on the thing that sodium and chloride are mostly extracellular and potassium and magnesium are intracellular. Calcium is also more in the extracellular compartment. Now, the principal electrolytes in intracellular fluid is potassium, and it has a key role in maintaining the transmembrane potential. Sodium is more in extracellular fluid and is responsible for maintaining osmolality of the blood. IV fluid therapy. Now, coming to the topic. IV fluids include crystalloids, colloids, and blood products. My talk would restrict it to crystalloids and colloids and our parenteral nutrient admixtures. These are the drugs. IV fluids are not simple water or fluids. These are the drugs with specific indications, dose ranges, caution, and side effects. And we have to institute this IV fluid therapy when, this hydration, effective circulating volume, and tissue perfusion are not adequately maintained by the oral fluid intake. So that is when we give these IV fluids to the patient. Now, dividing the IV fluids, mainly, these are divided into crystalloids and colloids. Crystalloids are your glucose-containing solutions, or electrolyte solutions, then mixed glucose with electrolyte solutions. And then we have colloids, which are divided into proteins and proteinaceous and non-proteinaceous colloids. Crystalloids, these are the solutions of sterile water with added electrolytes to approximate mineral content of human plasma. These are the initial fluid resuscitation fluids of choice in hemorrhagic and septic shock, burn patients, head injury, whereby we maintain the cerebral perfusion pressure, patients undergoing plasmapheresis and hepatic resection. For losses primarily involving water, replacement is with hypotonic solutions. If losses involve both water and electrolytes, then replacement is with isotonic electrolyte solutions. Now, dividing crystalloids further, we can divide these as per tonicity into hypotonic, isotonic or hypertonic. And it is pertinent to know these because dextrose 5%, which we are usually using in the OTs, it is hypertonic. Half normal saline is also hypertonic. Isotonic solutions would be your normal saline, ringer lactate, and plasma lights. Hypertonic salines or dextrose solutions are also there in the OTs and ICUs, and we use it in specific indications. Then crystalloids are divided on the basis of ionicity into ionic and non-ionic. Non-ionic ones being your dextrose solutions. So let's describe normal saline. Indications for this it provides major extracellular electrolytes, corrects water and electrolyte deficit, and substantially increases IV volume. It causes hyperchloremic metabolic acidosis as it contains high concentration of chloride, that is 154 milligallons per liter, as compared to plasma. Now, another one is Ringer's lactate or Hartmann solution. Names of two scientists are important as far as Ringer's lactate is concerned. One is Sidney Ringer in 1880 added potassium and calcium to normal saline to improve the cardiac contraction and cell viability and called it Ringer's solution. Then Alex Hartmann, who was a pediatrician, added sodium lactate to Ringer's solution to buffer metabolic acidosis, and this was then called Ringer's lactate or Hartmann solution. The advantages being no significant effect is there on acid-base balance. Physiologically, it is similar to plasma. Sodium lactate in Ringer's lactate is metabolized to bicarbonate in liver, which is useful in correcting metabolic acidosis. Disadvantages are serum lactate levels may increase in critically ill patients due to impaired lactate clearance because of circulatory shock or hepatic insufficiency. The indications for Ringer's lactate are severe hypovolemia, replacement fluid in post-op period, burns, fractures, diarrhea, induced metabolic acidosis and hypovolemia. In diabetic ketoacidosis, Ringer's lactate provides free water, potassium, and it corrects metabolic acidosis. Contraindications are shock, hypoxia, severe liver disease, severe congestive heart failure, vomiting or continuous nasogastric aspirate, wherein it worsens the metabolic alkalosis. And simultaneous infusion with blood, it is not indicated. Calcium in Ringer lactate inactivates the anticoagulant and leads to clotting of donor blood. Then drugs like thiopentone sodium, amphotericin B, doxycycline, and ampicillin bind with calcium in Ringer lactate, so leading to their decreased bioavailability. For anesthetists, the most important drug is thiopentone, so we should not use it with Ringer's lactate. Dextrose available in various concentrations, dextrose 5%, then this 5% in combination with 0.9% normal saline, in combination with 0.45% normal saline, dextrose 10%, 25%, and 50% with various indications. D5, the effects would be volume effect, protein sparing effect, lactate production, and hyperglycemia. So let's see further. It is indicated in giving calories to the body. When the patient is not eating anything, D5 gives us some calories. Prevention and treatment of dehydration, though not a fluid of choice. IV administration of various drugs. Prevention and treatment of ketosis in starvation, vomiting, and diarrhea. It protects livers against toxins and correction of hypernatremia due to pure water loss, that is diabetes insipidus. Limitations, herein we should not be using it. Neurosurgery, as it aggravates cerebral edema and raises the intracranial tension. Acute ischemic stroke aggravates cerebral ischemic injury damage by aggravating tissue acidosis due to anaerobic glucose metabolism. Then in hypovolemic shock, it gives poor IV volume expansion as glucose absorption leads to decrease in osmolality and increased cellular hydration. Moreover, fast infusion of dextrose leads to osmotic diuresis, which worsens shock. In hyponatremia and water intoxication, D5 worsens the condition. Hypernatremia, herein we should give it slowly. Otherwise, fast administration would lead to rapid correction of plasma sodium levels coupled with slow correction of brain cell sodium and leads to permanent neurological damage. Limitations, more limitations to be mentioned are blood and dextrose cannot be administered through same IV set, as hemolysis occurs due to hypotonicity leading to clumping of the RBCs. In uncontrolled diabetes mellitus, it again leads to more hyperglycemia. Then dextrose administration causes hypokalemia, hypomagnesemia, and hypophosphatemia. Next, crystalloid, DNS. Combination of dextrose with normal saline. It supplies major extracellular electrolyte, energy, and fluid, so corrects dehydration. It corrects vomiting or angiaspiration-induced alkalosis and hypochloremia along with supply of calories. Induces diuresis leading to increased urine output in partially corrected shock. It's not hypotonic because of sodium chloride and hence is compatible with blood transfusion. Limitations being severe hypovolemic shock, fast infusion of this causes diuresis and worsening of shock. D10 and D25 mostly used as source of calories. These supply energy, prevent catabolism, used for fast replacement of glucose in conditions like hypoglycemic coma, given in congestive cardiac failure, cirrhosis, and renal failure for fluid restriction. In liver diseases, as first drip, it inhibits glycogenolysis and gluconeogenesis. And then treatment of given for treatment of hypokalemia along with insulin. Limitations being not to be used in patients with dehydration, anuria, intracranial hemorrhage, delirium tremors. Rapid infusion would lead to glycosuria, so given over 45 to 60 minutes time in the absence of hypoglycemia. Plasma light, it is a low chloride crystalloid and with various contents as mentioned. Osmolality is same as plasma, 295 milliosmoles per liter. Acetate and gluconate are metabolized to carbon dioxide and water along with consumption of H ions, and this is the alkalizing effect. Coming to colloids, these are based on crystalloids. We say these have water and electrolytes with added components of colloidal substance. And they have larger molecular weight, more than 30,000 Daltons, which prevents pre-diffusion and restrict them to IV compartments. These retained molecules create osmotic force called colloid oncotic pressure. That is why colloids increase intravascular volume quicker and using less volume than crystalloids. These are 3 times more effective in expanding plasma volume than crystalloids. Now, crystalloids are divided into proteinaceous and non-proteinaceous. Proteinaceous ones being gelatin and albumins. Then, we have non-proteinaceous ones as starches and dextrans. Starches would include hydroxyethyl starch, pentastarch, and tetrastarch. Colloids again can be divided into natural and artificial. Natural being the blood products, fresh frozen plasma, albumin 5% and 10%, plasma proteins, artificial ones, again dextron, hydroxyethyl starch, and gelatins. Let's come to albumin. This is the main determinant of colloid oncotic pressure, accounts for 75% colloid osmotic pressure. It is the principal transport protein in the blood and inhibits platelet aggregation and thus maintains fluidity of blood. It is indicated in emergency treatment of shock due to loss of plasma, acute management of burns, pancreatitis-induced hypoalbuminemia, patients with liver cirrhosis after liver transplantation, therapeutic plasmapheresis as an exchange fluid to replace removed plasma. available as 5% albumin and 10% albumin and 25% albumin. 5% has 50 grams per liter. Colloid and cortic pressure herein is 20 mmHg, which is closer to plasma. Expands plasma volume to same as volume infused, and infusion rate would be 1 to 2 ml per minute. It is used as replacement fluid except in traumatic brain injury. 25% albumin. Proportionate 250 grams per liter. Colloid osmotic pressure is 70 mmHg. Expands plasma volume by 4 to 5 times of the volume infused. And initial infusion is 25 grams to be given at the rate of 1 ml per minute. Its use is associated with an increased risk of renal injury and death in circulatory shock. So to be used with caution in these patients. Starches. Hydroxyethyl starch classification is both based on molar substitution ratio, which is defined as number of hydroxyethyl groups per glucose molecule, and then concentration, molecular weight, then C2C6 ratios. This describes the hydroxyethylation pattern of carbon atoms in the glucose ring at C2C6 positions. Concentrations available as 3% hypooncotic, 6% as isooncotic, 10% as hyperoncotic. Then molar substitution ratios, we can divide these into hetastarch, this is 0.7, pentastarch 0.5, tetrastarch 0.4 molar substitution ratio, that is volume N, which is often used, and it is associated with increased morbidity in patients with sepsis and septic shock. Total parenteral nutrient admixtures. This picture shows it as 3-in-1, also called all-in-one. There are separate bags having glucose, fats, and amino acid solutions. Contents can be mixed to make TPN admixture. Depending upon the osmolality, may be infused through peripheral or central line. With those TPN admixtures, which have got osmolality up to 900 milliosmoles, can be used peripherally. And more than 900 milliosmoles, we give them through central line. These supply macro and micronutrients in one go, and also 3-in-1 bag. This prevents excessive handling of nutrients by the nursing staff. Now, intralipid 20%. This comes as 500 ml bottle and contains these contents: soybean oil, egg phospholipid, glycerol. The energy given is 2 kilocalories per ml. So one bag of 500 ml of 20% intralipid is going to give us approximately, 900 kilocalories. Osmolality herein is 350 milliosmoles per kg. Indications: it is used as a nutritional supplement as part of TPN for calories and source of essential fatty acids. It's contraindicated where abnormal fat metabolism and pancreatitis if it is accompanied by hyperlipidemia, dyslipidemias and liver diseases, and a patient having known hypersensitivity to egg, soybean and peanut protein. We must exercise cautions. Lipidemia must clear between daily infusions. And sometimes, just the inspection of plasma can be good enough to show that there is that plasma is clear. That means there is no lipidemia existing. Albumin toxicity may occur in a patient with kidney disease. Amino acid solutions, again, are constituent of TPN. With, 10% has got 100 grams of amino acids, which gives us 16.2 grams of nitrogen, and total energy is 400 kilocalories. However, we do not use it as a source of energy in TPN admixture. We try to complete calories from the fats and carbohydrates, and amino acid provides us proteins so that the catabolism is reduced or reversed. And these have got an osmolality of 1070 milliosmoles. This is given through the central line, and dose is 1 to 1.5 gram amino acids per kg body weight per day, depending upon the severity of the catabolic state and amino acid requirement. Now, herein I have shown the calculation of daily requirement. For a 60 kg stable euvolemic patient with moderate stress. So let's see, fluid, how much will we give? 30 ml per kg per day. In a 60 kg man, 1800 ml per day or 1.8 liters per day. Calories, 25 kilocalories per kg per day would come to 1500 kilocalories per day. Protein requirement, moderate stress, I'm writing as 1 gram per kg per day. Easy to remember, 60 grams per day. Fat requirement, how do we calculate fat requirement? 40% of total calories calculated. So like 1500 kilocalories, 40% would come to 600 kilocalories. And 1 gram fat gives us 9 kilocalories. So in all, we require 67 grams of fats. And carbohydrate requirement, easy to calculate. Total calorie requirement 1500 minus fat calorie 600. So would come to 900 kilocalories are required from carbohydrate source. 1 gram dextrose gives us 4 kilocalories. So herein we would need 225 grams of carbohydrates to give us 900 kilocalories. So 50% dextrose if we use, it provides 50 grams per 100 ml to provide 225 kilocalories. 450 ml of 50% dextrose needs to be infused. And electrolytes, trace elements and vitamins are added as per indication. These are available as separate solutions. And with this, thank you very much. I hope, you have understood this commonly used IV fluids, which sometimes, we are not able to respond in drug viva. These are the very important fluids. The examiner is very fond of asking IV fluids and then these parenteral nutrient admixtures. So thank you so much. Thank you.
Chat box.
So there's one question. After calculating blood loss, how to administer fluid considering crystalloid versus colloid? Latest guidelines considering the ratio of crystalloid versus colloid, 1:1 or 1:3 per ml of blood loss.
Earlier, we used to substitute 3:1 crystalloids for the calculated blood loss. However, now, the studies are showing the different perspective. We are even giving, studies are being done on 1:1 ratio. And, colloids, we are using 1:1, but crystalloids, I think 1.5 times the blood loss. That is how the practice is being advocated these days, and the studies are going on in this regard again. 3:1 is, however, not being practiced so far.
Fine. No, sir, there are no more questions. That's the only question that we had from delegates.
If there are no more questions, conclude the session. Unmute sir, please.
Thank you so much.
Thank you.
Thank you, sir. Thank you for your for being here, and thank you, ma'am, for such an informative lecture and making such a boring topic in a very interesting way and in a very useful way when it comes to appearing for the exam. So you just pinpointed the very essential things, very must-know areas. I'm sure it will help and benefit all the postgraduate students in their upcoming exam. Thank you. So we will move on to our next session for today. which is a short case presentation of a 54-year-old female with Colles fracture for open reduction and internal fixation. And